Thank you for tuning in today with our session CCT and Beyond. We're very lucky to have three speakers talking today on how to get your CCT and rounding out your final year in training. Miss Dora Moon from Royal Blackburn Hospital is going to talk to us on that, followed by Mr. VB Modgill talking to us on the first year as a consultant. And finally, we're very lucky to have Professor Kevin Turner from Royal Bournemouth Hospital and Bournemouth University talking to us on dealing with complications. So, without further ado, we have Miss Dora Moon from the Royal Blackburn Hospital talking to us about how to get your CCT.
Everybody, and thank you very much to BAUS and BSOP for asking me to do this talk again, and thank you very much to BAUS for putting all the hard work into making this virtual meeting a reality. So I'm Dora Moon, I'm a consultant urologist in Lancashire, and my subspecialty is upper tract, lap and robotics. I've got about 20 minutes to talk about getting your CCT. Now, hopefully, you'll all know how to get it. It's all documented very well in that ARCP checklist, and you'll be used to going through that at each of your interim meetings. So I'm not going to bore you to death with a very dry presentation about how you do it, but hopefully I can give you some tips things that I've learned during my training. I qualified in August 2019. Hopefully I can impart some wisdom as a result of my experiences and some of the pitfalls. Now, I gave this talk in Leeds at the BSOP meeting in February this year, and obviously times have changed quite significantly since then, and I was in the latter stages of my pregnancy when coronavirus really hit. So I've been out of clinical work since earlier this year, and obviously on maternity leave since July. But I know that the pressures that you all are under are a lot greater than they were, and you've got my deepest sympathies with the current situation and navigating your training. But hopefully everything that I said then still stands now. So we will get started. So attaining your CCT, it's all about going from this person on the left, who is a rather foolish CT1 dressed in a leopard print onesie at a morning handover, to the finished article, so a qualified consultant with a subspecialty. A lot of that goes with just growing up and maturing and realising that that was probably a very unprofessional thing to do. Incidentally, that photo was taken in the hospital that I currently work in as a consultant, and to date nobody's mentioned it to me, so either they're being very polite or hopefully they've just completely forgotten. But the bit of that journey that I'm going to focus on today is the final bit, so your final year. That last 12 months is really key. And I don't think I really appreciated how stressful I was going to find it. So we'll talk a little bit about my experience, but you may have noticed that the background of my slides is a mountain. We all love an analogy in urology, and I love mountains. So I'm going to use a very cliched analogy of climbing a mountain to draw parallels with your training in urology. Now, mountaineering requires skill, it requires endurance and experience, and therefore the parallels are very clear with a demanding 5 years of urology training. So I shall flog this analogy to death and start with some of the key parallels that I've drawn between urology training and mountaineering. And any of you that have done any kind of endurance sports will understand the commitment and required in these disciplines. But it's not a mystery about how to get to the top. It's not a mystery about how to qualify in urology. It's well documented, and there are multiple resources that you can access for both your training and both mountaineering. So there's really one key element that underpins both sides of this mountain, and that is preparation. So I'll come back to this in a bit and you'll understand why I'm going to talk about preparation. But to continue with my analogy, I want everybody to really think about a time they set out to do something and they failed to achieve it. And to reflect on those reasons why you may have failed. So learning from your mistakes is a normal part of becoming a good doctor and a good urologist. And there will be pitfalls along the way, and we've all made mistakes, but it's how you evolve from those mistakes that make you the person that you are, and allow you to progress. So in terms of why I'm talking about this and why I'm talking about my failure, is hopefully I'm going to draw it back to this keyword of preparation. So this photo, this is taken just below the summit of Mont Blanc. So it's the highest mountain in Europe. And it's been somewhat of an obsession for myself and my husband, this mountain. We had shared passion for mountains all of our lives, but this one in particular was something that we wanted to achieve together. So in the first month of my ST7 year, we flew out to Chamonix together to try and conquer Mont Blanc. And this is a photo of my husband at the summit. And sadly, I am not the one taking the photo because I didn't make it to the top. And I'm going to talk to you about this failure because it still stings today. So as much as I wish that this photo looked like that, it wasn't the case. And he summited without me. So back to preparation. These are just some of the shots that I took in the month leading up to the Mont Blanc attempt. I did everything possible. I threw everything at my training and my preparation. So I undertook training in the UK and France, so in alpinism, so roped walking, traversing, trad climbing, bouldering, ice climbing, walking with weight, strengthening and conditioning. Even did some glacial experience, so learning how to traverse glaciers, self-rescue and emergency techniques, and just spent hours and hours and hours on my feet with a pack on in North Wales, in the Peak District and Lake District. And this is my quick advert for the Northwest. So if any of you are wondering where to base yourselves in the future and you love the outdoors, the northwest of England is a brilliant place to live because we have some of the most spectacular scenery within a couple of hours of Manchester. So, right, I'll digress from that. So I looked pretty prepared and I felt prepared. I felt like I'd done everything to increase my chances of getting to the top of that mountain. But there was one key thing that I left to chance, and that is boots. So I had a pair of mountaineering boots, but for Mont Blanc, you need what's called a B3 boot, so really rigid, they take a cramp on, and they are pretty expensive. So I decided to cut a corner. I was a cheapskate and I decided to hire a pair instead of buying a pair. So when we got out to Chamonix, I hired a pair of boots, and the company we went with needed us to do two pretty arduous acclimatization days to prepare for going up Mont Blanc. So day one, we went up to something like 3,000 meters, and this was what my feet looked like at the end of day one. So those hired boots absolutely destroyed my heels, and no amount of Compeed or tape could dull the pain from those blisters. So that was it for me. I couldn't complete the second acclimatization walk, and therefore I couldn't even attempt to even go up Mont Blanc. And in that moment, it was all over. So all my effort and training was lost just on the basis that I took a chance on a pair of boots. So I spent a lonely few days in Chamonix as my husband and the rest of the group set out for the summit. I did decide to go paragliding just to try and cheer myself up because I was on my own. And this is actually a picture of me being allowed to have a go at steering the wing. Ultimately, it ended up being 20 minutes of staring at the summit of Mont Blanc. So it was really not the uplifting experience that I was hoping for. So maybe I'll try it again another day. So other than reminding myself of this stinging failure, the point of the story really is to never leave anything to chance. That failure taught me a lot from a mountain point of view, but also from a professional point of view, as I was going into my final year of training. And the bottom line of this strange story is to prepare for ST7 before ST7. You need to do as much as possible to prepare for that final stage, because the requirements of you in that last 12 months are pretty significant. And so I want to move on to talk about then the elements that I think you really need to prepare for before you get there. And obviously you kind of you should never really lose sight of those things throughout your sort of 4 to 5 years. And the first one is that Ctt checklist. So at the beginning of this talk, I said I could have just put this up as a PowerPoint slide and talked you through it, but you all know it, and you should all have ready access to it, whether it's on your laptop or on your phone. But you know, this is a constant reminder of everything that you should be working towards. Now, nobody goes into ST7 with all of these complete. I'm sure there's the odd loudmouth that may proclaim that they've done everything before they've even entered that final year, but the vast majority of people will be going into that last 12 months with some of this still left outstanding. But obviously the less you have, the better. So you need to plan in advance of what is achievable, and obviously don't leave things until the last minute. Now, waypoints have been brought in, and they really help to try and structure your training a bit better over those 5 years. That didn't exist when I was training, and a very kind, outgoing ST7, when I was an ST3, wrote me a 5-year plan, essentially detailing those key targets to hit at what point. So really, you know, every year you should be setting yourself realistic goals, and those initial meetings and PDPs that you set, they're not just box ticking exercises. They're really important. They help you detail what you want to achieve that year and help you keep track of it. So really set yourself realistic goals at the beginning of each 12 months, but keep in mind that you don't want to backload that at the end of your training. And one other bit of advice really is to not take on too much. So it's really tempting at the beginning to just say yes to everything at the start of a new rotation. You don't really want to let anybody down. And then you can find yourself 6 months in with a load of unfinished audits and projects. So it's okay to say no to well-meaning consultants, but pick a project that's going to have legs, that's achievable in that year, and otherwise say no to everything else. So ST7 is a demanding year. Don't make it more stressful than it needs to be, ultimately. Secondly, it's your subspecialty. So this isn't a requirement necessarily for your CCT, but it's definitely something that I wanted to talk about today. Because when I started my ST7 year, my indicative numbers were nearly all finished, save for a few TURPs. But that gave me the freedom to concentrate on my upper tract operating and not having to chase other lists in order to make sure my indicative numbers were all boxed off, and there was no other distraction from what I actually wanted to be doing and training on. Now, your waypoints is another way of structuring your indicative numbers and when and how you should be achieving them. But it's highly likely that you are going to go into that final year with some numbers still outstanding. But obviously, the less, the better. Now, there will be people watching who have already decided that they want to do a fellowship, and that's great, and that will take the pressure off that final year for sure, because you know that you've got another 12 months of purely dedicated training still to come. On my part, it wasn't a particularly easy decision to not do a fellowship, but if you have a productive ST7 year, it can simplify that decision for you if you are unsure if you want to pursue one or not. I didn't go down that road, and I'll talk a little bit about my consultant job next and what I've ended up doing. So the consultant job for me was the main stressor of my final year. It sort of lingers over you throughout, and it's a 15-minute presentation in itself. So I'm not going to go into it in too much detail, but it's not a requirement for your CCT to have a consultant job. But you have to bear in mind that most people will be interviewing and accepting fellowship or consultant jobs before their final ARCP. So when you're sat there in front of the panel, you really need to know and be confident that you've done everything required to gain your CCT. The level of stress I think you put on yourself, if you know that you've still got several things still left to do, time's tight, it's not necessary. You don't need to do it to yourself. So if you go into that interview confident that you know that you've checked off that Cct checklist and you're golden, and you can sit there confidently knowing that you deserve that job. So I think that's really important. In terms of the decision itself, it does feel pretty substantial. It's the first time in your entire career that you make the decision, and it's a long-term one potentially. No one can make it for you, but my advice is to speak to as many people as possible. So get advice from the people that you trust, whether that's friends or family, colleagues, and visit these departments, but definitely more than once if you haven't worked there before. Speak to the right people, ask the right questions, weigh up the pros and cons. Now, for some people, the decision might be really easy. You've worked in a department before, there's a job lined up and it all seems meant to be, and that's amazing. But sadly, that wasn't my experience, and I think that's why I maybe found it more stressful. But ultimately, I've ended up in an incredibly supportive department. They've given me the trust and confidence to be doing the kind of operating that I trained for and I aspired to. So I do count myself very from that point of view. So due to the fact that I could go on about this bit for ages, I'm going to leave my email address at the end of the talk. So if anyone's got any questions, you can email me. I'm happy to answer them. So the last element is yourself, so self-care and your life outside of urology, which is definitely on a par with all of these. Everybody strives for work-life balance, and at times it can feel absolutely impossible to achieve. But if you don't make time for yourself, you'll end up burned out. And after my failure in Chamonix, I stopped climbing, I let my fitness slip, and it really did take a few months for me to snap out of it. So myself and my husband, we set ourselves new goals, but we knew that we wanted more mountain adventures together. And I personally thrive off the aim of having something to aim for. And each of you will have your own ways of escaping work and deriving fulfillment elsewhere. For us, we wanted a new target. So in a nice sort of tying up at the ends of my mountain analogy, this is me at the top of Mount Fuji. So this is exactly 1 year after the Mont Blanc disaster. We flew out to Japan and we summited the highest point in the country. I set myself realistic goals, I prepared, but most importantly, I took my own shoes. And that's me looking very happy with myself. Now, it's not the 4,000 plus meter mountain that I wanted to achieve, but I know that one day I will stand on the top of Mont Blanc. I just don't know when, now that I've got a little baby. So having a focus outside of work is really important. And your ST years are often a time of big life changes. So buying a house, getting married, starting a family. And for me, in a really weird parallel, on the day of my, I was awarded my outcome 6, I became an auntie to my little niece. And since I gave this talk in February, I've given birth to a baby girl, and life has definitely taken on a new meaning for me. I found out the new levels of tiredness, of exhaustion that I didn't know existed, that you can actually be more exhausted than after a 48-hour weekend on call. But family is going to be a constant throughout all of this, and currently family time has been taken away. So myself, like lots of you, have been under extra restrictions since July. I haven't been able to see family indoors, and social lives seem like a distant memory. So now more than ever, I hope that you are all taking care of yourselves, and you know, I'm sure this is a far more difficult time to be a trainee, and again, you have my sympathies, and I really hope that you are able to have things outside of work that you can do to deal with the other pressures that you have. In terms of a career in medicine, you know, it is very competitive, and you can often be left feeling guilty for neglecting both your personal life and your professional life. You come across lots of loud voices that will proclaim how many projects they've completed and, you know, how far along they are on their checklist. They'll tell you that they haven't taken their annual leave this year in a very strangely proud manner, but you know, those voices, you really need to tune them out. Don't listen to them. Concentrate on yourself, concentrate on your happiness, and concentrate on the things that you need to get through your training. So that's about it from me. This is my email address. It's my personal email address, so please don't share it, but if anyone wants to email me about my training or my experience, I'm really happy. I can't answer any questions about getting to the top of Mont Blanc. Sorry, you can have my husband's email address if you want it about that. But otherwise, thank you very much for listening and enjoy the rest of the session.
Thank you for that enlightening talk, Dora. We are now very lucky to have Mr. Modgill.
Okay, hello everybody. My name is Vaibhav Modgill. I'm a urological surgeon and andrologist in Manchester at the Manchester Andrology Centre, and I'm very pleased and very privileged to be asked by Sok Tolafari and the rest of the BSOT team to come and speak to you about my first year as a consultant here in Manchester. I was appointed in September 18 and I started in March 19, so I've hit just about the 18-month point now. So I'm really just going to share with you very much my experience. I don't think this is the experience because everybody has a slightly different one, and I'm hoping to keep it pretty informal. Slightly strange as obviously I can't take questions as we go, but I'll try and elaborate on points as much as I can. So really it's about putting certain things into context, knowing a little bit, I guess, about my background, where I trained, setting out some of my expectations, or certainly what they were when I came into the job, what I've found to be the reality of it. And I've got a section called It's Cliche, but it's true, because you'll all know that as you go through your training, people tell you, oh, it'll be like this and it'll be like that. And some of that isn't true, but some of the things that you hear time and time again really are cliche for a reason, because that's pretty much how it ends up. And then I've got a little section on what I would do differently, which isn't very big because I'm very fortunate to work where I work. And essentially the job has been everything I thought it would be. So a bit of context, I'm a slightly strange individual. I knew I wanted to do urology from the 5th year of medical school in Southampton. I did a dedicated year of urology in my 4th year and realised quite early that that's what I wanted to do. And then I had a house job doing urology in Worcestershire, and that was in 2007-8. And I remember, again, a slightly strange individual taking a week out to go and visit Professor Ralph's unit at UCLH, because I'd heard about some of the sort of rarer work that they were doing. And I went down there, met Prof, some of the team, watched some of these operations, including things like phalloplasty and genital reconstruction, and was pretty much sold really that urology was the way forward, but maybe not only that, but perhaps even andrology. I had a bit of a wobble at F2 because I absolutely loved my plastic surgery job at the Queen Elizabeth, and briefly thought about doing that, but I suppose andrology gave me the option of doing things like plastic surgery operations, but more in the sort of genital area. I then moved to Manchester for my core training, and I had a very early breakfast career advice meeting with a chap called Ian Pearce at Manchester Royal Infirmary, and that was almost 10 years ago, because I wanted an ST3 number in urology, and I wanted to know what I should be doing, what I shouldn't be doing, were there any papers that I could write, etc. I spent 5 years in the West Midlands on the Birmingham rotation doing my ST3 to 7, and was very fortunate to go and do a year in Perth in Western Australia. And at that time, that was an out program experience, so it didn't count towards my training. And that fellowship was incredible and taught me so much. I then came back from that and did a dedicated subspecialty fellowship in my subspecialty andrology at UCLH, and as many of you will already know, it's a phenomenal fellowship in terms of numbers and the exposure. It's probably one of the best in the world, and again, very lucky, very privileged to have had that opportunity. I interviewed in September 18, as I said, and then I started my job here in March. So there's a few pictures of the journey, and as ever, people only really show you the good pictures, don't they? And so on the top left and the right is Perth, of course, and that's a place that remains very special in my heart. And then those are two mentors that I had, obviously Asif Munir and Prof Ralph, when I did my job down in UCLH and learned a huge amount. And then, of course, I was appointed at Manchester Royal Infirmary at MFT, and that was a pretty awesome day. So what were the expectations? I guess the expectations for me, I know people say that things change now, but it was always going to be a job for life. I never ever thought about taking a job where I would maybe move again in 2 years or 3 years. Hopefully that doesn't happen, but if it does, we'll wait and see, but I really hope it doesn't. Broadly speaking, get your head down, do your work, and the rest will work itself out, I suppose. I wanted to go and work at a teaching hospital because of what I wanted to do with andrology and penile implant surgery. I don't think I ever really had the option of not going to a teaching hospital because it's reasonably specialist work. And of course, we're very fortunate at MRI to have such a large volume in terms of inflatable penile prosthesis. We're now the second largest centre in the country after UCLH. I knew pretty much, because I'd been told that I'd do on-call at Christmas and maybe even New Year's Eve. And certainly one of those came true because I was on call at New Year's Eve. And of course, the Friday afternoon clinical session to make sure that someone's in the building. And that also came true because I was given a flexi list, albeit with normally a trainee. So it wasn't too cumbersome. What did I have in my mind? Well, I had to repay the faith that had been shown in me by colleagues who I'd been in discussions with before my interview, and I had to add to this already big department, which had quite a reputation before I came into it. And that meant clinical, academic, being a team player, and following in the footsteps of role models. And I suppose you have your personal expectations, and there is a picture of my dad who retired the year before last, and I very much grew up with this image of that's what a consultant is, that's what they do, that's their work ethic, that's how they look, etc. And so, you know, on a personal level, it was to try and follow in similar vein. I was worried about moving to a new city. I was worried about the on-call. I think that's a pretty common one, the on-call, because you think, well, what happens if you get an open ureteric injury? I haven't done that many of those, etc. In reality, those things thankfully are very rare, and also there's always somebody around, really, especially if you work in a supportive environment. Secretaries, would I have one? What would my colleagues think of me? Obviously, you do your interview, and your job at the interview is to sell yourself and say, you know, I've trained in 2 places, I'm subspecialty trained, etc. But then when you start the job, there's definitely a moment where you think, have I maybe convinced these people that I am better than I actually am, and maybe I'm not up to it. And so those were some of the anxieties, really. From a personal point of view, I was looking forward to life settling down. As a registrar, it can be incredibly hectic, the daily ward round. For some people, young families that come with that. Wanted to buy a so-called proper house, as it were, and settle my family down. And I've been telling my wife for about 15 years that don't worry, once you become a consultant, it all gets so much better. So I had to prove that to some extent. And of course, more school drop-offs, pickups, and just have a bit more of a balanced lifestyle, really. So this was the reality on day one. There I am, ready to go to school on my first day. My wife took that picture. That's my new bag that she brought me to go to work with, which is a bit of a prized possession now. And there's the picture of my badge that I took and then rapidly sent to loved ones, particularly my parents. We sat down, we talked about my job plan, and as you can see on that piece of paper, that was basically my job plan, jotted down on the side of A4, and that's how it was going to be, certainly for the first 6 months or so. And as I walked around the hospital, I saw posters of Ian Pearce, who's of course the colleague I work most closely with, and is in no small way responsible for me coming to Manchester. And I realised, wow, there's an act to follow if you've got posters that size around the hospital of you. So what was the reality in the first 6 months? Well, they were incredibly pleasant. So I started on a 10 PA job, which most people start on a 10 PA job. And normally, depending on what the balance is between direct clinical contact and not, it should be quite pleasant. It shouldn't be particularly cumbersome. I didn't take over anybody's job, so I didn't have a backlog of patients or people that I was ready to see. So new clinic templates were set up and I had some say over what they would be like, when they would be. And there was a predictability to it all, which is really pleasant after coming through registrar years. An alternate week theatre to start with, and some people I know discuss that sort of endlessly before they start. Certainly wasn't the end of the world for me, because I did a lot of joint operating within in my first year, and still do for certain cases. And of course, that does mean that when you do have your free slots, you have to be a little bit flexible about filling in, etc. And again, it didn't bother me very much at all. I think that's the norm. A couple of MDTs, and of course, I had Tuesdays with no clinical activities because I was on 10 PA, and that really is a whole different concept that you just never get as a registrar. How could you possibly have a day where you don't do anything? Well, certainly I didn't, because I never had 0 days and things like that. So a big part of it was doing implant surgery, which I'd learned to do at UCL, but I came to Manchester and then learned the infrapubic approach. And I didn't have very much admin because, obviously, as I said, I didn't take over anybody's jobs. I did lots of conferencing, did BAUS, AUA, as you can see there, met with old friends, also managed to go to the EAU, and I really enjoyed Manchester. I met one of my lifetime heroes, Robert Pires, who you can see in the picture there when Arsenal came to Manchester to play. And I was invited to join Manchester Urology, which is the private group within which I now work, which was unexpected but pleasant. 6 to 12 months, it was still 10 PAs. It definitely felt like more because I was saying yes to more and more things. The workload does pick up. It picks up quicker than you think it will. The rest of the week remained pretty predictable. However, there was then a drive from me to try and establish the male infertility service here on board with my colleagues at the Reproductive Medicine Centre. I'm pleased to say that that's now come to fruition. Tuesdays again were free, but you find that as the admin and teaching and the academia starts to ramp up, your free time definitely becomes sort of less and less available to you. The implants continue to grow. Certainly confidence grows, doesn't it? The more you do of something, the better I think you get at it. So starting to do more challenging cases and requiring less and less support with those. And you find that the email traffic starts to go up, and not all of it's important, but people expect you to reply, of course. I was very fortunate. I got invited to BBC Radio 5 Live to do a men's health segment, and really, really enjoyed that. That was one of the highlights. I travelled to Miami to do some implant surgery there, which again was fantastic. And although I had said yes to joining Manchester Urology, I beg your pardon, I hadn't quite started yet, because in my mind I was quite certain that for the first year, certainly I wanted to just get my feet under the table, NHS-wise. So what about the reality 12 months onward? Well, COVID happened, and that threw a real spanner in the works, as you all know, and those are some of the pictures that really outline that time. Met another footballing hero, Mo Salah, out and about on a bike ride, and I thought, yeah, I like this place, I'm glad we live here, and built a social distancing bar in the garden. So those were some of the home life things that I did. And of course, work became very challenging, because any pattern that I'd established, any predictability that I'd established, suddenly went out the window. It did for all of us. And so in a way, we went back to that sort of on-call shift work. We made some quite drastic changes with the rota, having 2 consultants on at any given time. Reorganization of patients was quite stressful, really, because although luckily I didn't amass that many patients in the first year, you still feel this degree of responsibility, I think, that you probably never felt before as a registrar. I was very pleased to have the fertility clinic set up, and of course then that took a bit of a backwards step because of COVID. And then I'd also increased my workload to 12 PAs, and suddenly my plate really was full with your own trainees, medical students, setting up a research collaborative, helping out with an MSc, and then the several roles that I've tried to keep going with BAUS, EAU, the exam board and ISSM, etc. Suddenly the email traffic really does ramp up, and you almost dread looking at them in the morning. But I think the key is to just consistently bash away at them, and eventually you end up dealing with all of them. It was only really at the 12-month mark, I think, that I started to learn the art of delegation a bit more, and I'm quite obsessive about my calendar now, and that's, I don't think, certainly for me, is no bad thing. Appraisal and job planning come to the forefront of your mind, because it's not really until your first appraisal that you understand the process. And job planning is in itself quite an intricate thing. So knowing exactly how to construct it, finding a way to do it so that it really suits your working week. And that can take time and rejuggling and reshuffling. And that's normal. I don't think anyone should be surprised by that. I did some extra work as well, and of course that meant extra admin. So, you know, seems obvious, but something to be wary of. That as you see more people, as you do more operating, all the admin that comes with that can be quite substantial. The system, without a shadow of a doubt, is more important than you. So have a system in place, a reliable secretary, which I have on all fronts, is brilliant and absolutely invaluable, because they keep you on the straight and narrow. And so really reflecting back on it, what can I say? This is it's cliche, but it's true. Time off before you start. I had a couple of months off. It was absolutely brilliant. I went away on holiday a couple of times with the family, and you don't ever get that time back, because I suppose once you cross the line and you are the consultant, you'll always be in that position, and there'll always be your patients. So even though you might have time off, it'll never be a completely clean slate. People said to me time and time again, pick your colleagues very carefully, and how right they were. I've had a brilliant time working where I work, and I would definitely not change it. And a lot of that was having conversations before I started, making sure that I suppose we were all on the same page, but also in terms of mentoring and working with Ian and working with him so closely has been a huge support. And so I would encourage anybody looking at a job to look long and hard at where you're going to work, because it's true, you spend a lot of time there, and those are the people that will support you through the good and the bad. If it looks like it and it smells like it, it probably is it. So I knew I was coming to a big trust, which is now the biggest trust in England, I believe, and that would come with expectations and aspirations. And of course, that also comes with you know, a degree of competition, not only within where you work, but also if you do things that are particularly niche, then that means regionally as well. And those aren't things that I think you're particularly well prepared for as a registrar. But if you just stick to the ethos generally, I think, of working hard and doing the best you can, then hopefully the rest of it will slot into place. Funding, I think, speaking to colleagues around the country and friends around the country who are doing the same job, sometimes can come a bit easier in bigger centres. And things like professional leave, I did a lot of lectures last year and things, and again there was a bit of leeway made for that, provided I moved my clinical commitments around. Do walk the corridors in the first 6 months and smile, and do get home early. It's a really nice feeling. You've worked long and hard for it, and hopefully you've got the job that you always wanted. And so take it all in, because as time goes on, you get busier, and it does, I suppose, become more of a norm. Don't say yes to everything or most things unless you want to. And I suppose I did say yes to quite a few things, but I found that very useful and very fruitful and stimulating. But it's entirely up to you. So I think sometimes people say, well, don't say yes to everything, or be very careful about what you say yes to. Yes, that's true, but equally, when you do pick things up, it opens opportunities up, opens up doors, and you learn a lot about yourself fairly quickly. Ask for help if you need it. There's always someone around. That's so true. I couldn't agree more. Certainly in my case, my colleagues were and again, I'm very lucky to have that around me. Think before you type an email. As the number of emails go up, you tend to send quick fire responses, and you learn over time that sometimes you just ought to have a bit of a think. I haven't done anything too disastrous, I think, but it's a good thing to remember. And I suppose a reminder to myself, as much as it is a cliche, but Rome wasn't built in a day. And I think you just have to stick to your core principles of staying focused, have a mentor. I can't underline how important that is. And lastly, don't be in a rush to start private practice. I have started now, but it's incredibly slow, which is okay, because I think that's how it is for everyone. And again, it's probably worth enjoying the fact that it's slow. So what would I do differently? I'd worry less. I think that's pretty much impossible. I'd be less indulgent with food and be maybe less content and therefore put on less weight. I would stop COVID, which of course none of us can do. I travelled a lot last year, and I travel maybe just a bit less. I'd set up Excel sheets for everything from the get-go. I have for most things now, but recording data is so valuable, and I don't think you'll ever regret recording it. You might regret not having it. I wouldn't say to my wife again that I bet you it won't rain that much in Manchester, because it does. And I've got regular leave, because I got to the end of last year and realised that I basically hadn't taken any leave. And I turn off email when I'm on leave, and I'm hoping that I'll learn that skill soon. So that's really it. From my point of view, I don't think there's anything else to add, and I'd be very happy to receive any emails or text messages or anything like that for anyone that wants to ask any questions.
So we're very lucky to hear from Professor Kevin Turner of Royal Bournemouth Hospital and Bournemouth University, talking next about dealing with complications. And I know I've had a few, so I look forward to knowing how I should have dealt with them.
Well, thank you very much, Neil, for that introduction. And it's a real pleasure to participate in this session, CCT and beyond. And I'm delighted to be sharing with you some thoughts about dealing with complications. As Neil has said, I'm a consultant in Bournemouth. My clinical interests are in pelvic cancer and robotics, but for a number of years, I've had a research interest in the impact that adverse events and complications have on surgeons. When I was a trainee, I was fortunate that people taught me lots of things. People taught me things about clinical urology. They gave me clinical experience. They taught me how to operate. I learned about how to conduct and evaluate research. I learned something about what is meant by quality improvement and how to seek it out and deliver it. I learned about how to receive and hopefully give medical education. I learned things about management and leadership, and I went on lots of courses, some of which you will recognize as being urology specific and some more generic. And I even went on a pre-consultant course that covered such topics as dealing with difficult colleagues, and even strayed into the great unspoken topics of private practice and career planning. But no one ever said to me when I was a trainee, when you are a consultant, some really bad things are going to happen. Some really, really bad things are going to happen, and those things are going to affect you. Darrell Campbell is Emeritus Professor of Surgery in Michigan. He's devoted much of his professional life to aspects of surgeon well-being, and he has said, in the classic training program, we have taught how to perform surgery, but we have not taught how to live as a surgeon. So that was Darrell Campbell in this century. If we go back to Hippocrates, as far as I know, he never actually said, first do no harm, but he did say words to that effect. He said in the Hippocratic Oath, I will prescribe regimens for the good of my patients according to my ability and my judgment, and never do harm to anyone. And from that, we get first, do no harm. He was a wise character, Hippocrates, and in addition to that which he's so well known for, he said this: the life so short, the craft, perhaps we could say surgery, so long to learn, opportunities to learn fleeting, experience treacherous, and judgment difficult. And it was one of my mentors who said to me that good judgment comes from experience, and experience can only come from poor judgment. So obviously the first part of dealing with complications is to try to avoid them in the first place. I'm not going to spend much time on this, but it's important, I think, to develop an interest, to call that your own, and to make it your ambition to stay up to date, both in terms of your skills and knowledge in the area in which you want to make your own. Returning to surgeons ancient, this is Albucasis, who said, wisely, I think, before practicing surgery, one should gain knowledge of anatomy and the function of organs so that he will understand their shape, connections and borders. He should become thoroughly familiar with nerves, muscles, bones, arteries and veins. If one does not comprehend the anatomy and physiology, one can commit a mistake, which will result in the death of the patient. I have seen someone incise into a swelling in the neck, thinking it was an abscess, when it was an aneurysm, and the patient dying on the spot. JFK thought that doctors should know what they were about. He said, in my opinion, the doc who operated on him for a disc prolapse, in my opinion, the doc should have read one more book before picking up the saw. So key to avoiding complications is obviously to start with a comprehensive understanding of anatomy and all its variations. Forgive me using that excuse to put in this great slide. Yes, that truly is a kidney in the medial thigh with an excreting ureter overlying the femur. So you've got to know about all the potential variations. You've got to be good at what you do. You've got to consent adequately. And I was deeply struck by this editorial from Daniel Sokol, the barrister and medical ethicist from the BMJ very recently, on which he comments on the new guidance from the GMC, which becomes live in November. And the GMC has really laid out very clearly what constitutes meaningful consent. And it's really worth a read of that editorial. I think many of us will be taken aback about just what level of detail is now required of us by our regulator in terms of the consenting process. So patients have got to be consented, because you don't want to end up like this. We're calling her Sue after what we're going to do with the surgeon who did the vasectomy. So consent adequately, describe what you're doing accurately, record fully, write contemporaneously. When things go wrong, apologize promptly. Assume responsibility when it is your responsibility, or when it's the responsibility of someone for whom you were responsible, be it your trainees, junior doctors, or any other member of the wider medical staff. Support people appropriately when things have gone wrong. Again, your trainee, your colleague, and all those involved and affected by an adverse event. And throughout all of this, demonstrate and express kindness always. It is, of course, a great truism of what we do, that people remember less what we say and more how we said it and how we behaved. But no matter how good we are at anticipating and avoiding complications, and no matter how skilled we are and up to date in our area of special interest, the fact is that as surgeons, we often walk perilously close to the edge, and it doesn't take much to go wrong for us to fall over that edge. So complications are an absolutely inevitable consequence of the surgical life. Of course, it's true that the only way to have complications, the only way to avoid complications, is to treat no patients and do no operations. The extent of adverse events is quite remarkable. 1 in 10 hospitalized patients experience some sort of adverse event as a result of the medical care which is meant to make them better, and the majority of these are related to surgery, and 7.4% of those adverse events are lethal. So, ladies and gentlemen, it is, of course, impossible for us to avoid complications in our surgical life. And what I'm interested in is what's the impact of that on the surgeon? What can be done to reduce that impact? And for that matter, why on earth isn't there a course if this is an inevitable aspect of consultant life and we prepare people for so many of the other things that we think are inevitable aspects of consultant life? What do we know already in this area? Well, there's quite a lot of literature about burnout and stress in medics, and that literature describes the incidence and prevalence of burnout and stress across doctors of various specialties in various countries and of various seniorities. If we hone down perhaps more specifically on medical errors, the literature has linked medical errors to the incidence of burnout, to depression, to suicidal ideation, to reduced quality of life, to increase likelihood of subsequent error. In other words, when something goes wrong, the impact that has on a practitioner may mean that they're more likely to make errors again. And there are multiple publications in the last couple of decades which very movingly and viscerally convey physicians' feelings of guilt and shame and inadequacy after a medical error. And it was Albert Wu, writing in the BMJ in the year 2000, who first coined the term second victims, a term which has some controversy attached to it. I'm not going to dwell on that, but I think even if you don't like the term, you get the point that those delivering medical care can be affected too when things go wrong. There is a problem with the existing published literature on this. The vast majority of it, the overwhelming majority of it, comes from the United States. Nearly all of it mixes up and confuses errors and complications to an extent which has always surprised me, and as I hope I'll illustrate, the difference between errors and complications could be really important. And very little of this literature is specific to surgeons, and again, that surprises me, and I know I'm speaking to a sympathetic audience when I say that there are some aspects of surgical practice which are unique or nearly unique to surgery, which make the impact of adverse events on surgeons particularly worthy of study. Only in surgery is there such a direct perceived link between what the surgeon does or doesn't do and the outcome for the patient. Now, fortunately for all of us, and we're all urologists are nice people, and I'm sure that many and hopefully all of us work in units where there are already support mechanisms, and you might recognize some or all of these big four. When something goes wrong, hopefully someone will tell you that you're good. They big you up and build you up. You're good at what you do. I'd let you operate on me or a member of my family. They will remind you that bad things happen to good people, and even good or great surgeons get complications. They will seek to reassure you about the ubiquitous nature and inevitable nature of complications by regaling you of a story of something that happened to them. And then finally, they will encourage you that it's time to get back on your horse, to get back into theatre, to get a knife back in your hand again, and to get on with surgery. And of course, all of these things have great value, but they are inadequate in terms of response. And we know they're inadequate because of the really moving things that people have said to our team in Bournemouth when we've spoken about the impact of adverse events. Here is a quote from a consultant urologist who made an error of identification of anatomy, which resulted eventually in a patient's demise. I felt and feel very guilty, but I remain disappointed by the lack of support from my employer. I felt I was treated like a criminal first, rather than any duty of care to me as an employee doing his job. I found it very difficult to talk about at home. It was only the support of my colleagues that enabled me to get through that period. You know, it's definitely not enough when people write things like this. It always feels callous to talk about the impact on yourself as the surgeon when you know the family have suffered so much more. Unfortunately, my trust really didn't know how to handle me or the process, and I was not well supported. So though there are existing support mechanisms, although some of them are good, they are clearly and hugely inadequate. So one of the things we've sought to do in the work we've been doing in Bournemouth is to get a really up-to-date and accurate picture of the impact of adverse events and complications on surgeons in the UK. And I'm not going to dwell too long on this, but I wanted to show some of the data that substantiates some of the things I'm going to say. So we have detailed questionnaire information from 445 participants, mixture of consultants and trainees. We asked them to comment on an event and they were randomized to comment on one of their errors or complications. And we collected detailed data about the severity of the event contributing to it, about the emotional impact that an adverse event had upon them, about the impact on their health and behavior, about the impact on their professional practice, about the outcome in terms of sanction or restrictions to practice, and about how prepared they felt to deal with the impact of a complication when it came. And here's a summary of some of those bits of data. And the fact is that adverse events make us feel absolutely awful. And although anyone who has experienced an adverse event won't be surprised to read some of this, I remain deeply struck by just how much adverse events impact upon us. 50% of people who responded to our survey said they were more anxious in life because of this event. 48% admitted to increased problems with anger or irritability. 42% of people have sleep problems as a result of an adverse event. 10% drank more alcohol, and 11% admitted to being depressed. We asked specifically about Pts symptomology, been a lot about that in the medical press for those who have had the very challenging experience of dealing with the COVID crisis. And there are 4 key characteristics to Pts symptomology, and those things are detachment, hypervigilance, nightmares, and avoidance behavior. And the majority of our respondents displayed at least one of these 4 key PTS characteristics, and 30% displayed at least 2 of them, and 2 PTS symptoms are regarded by psychologists as clinically significant in terms of PTS symptomatology. So, you can see from this data that when adverse events happen to us, they have a profound and broad impact upon us. Unsurprisingly, then, almost everyone agreed that training should prepare a surgeon for an adverse event, but almost no one thought that surgical training did. Here we have something which you can't avoid and which is going to affect you, and which as a profession we are failing to prepare each other for. 60% said that an adverse event had changed their surgical practice, and 20% found that change difficult or very difficult to deal with. It's not all bad news. We learn when things go wrong, and 36% said their practice had improved. 33% said they were then better placed to be able to help others. 9% said they now avoided particular procedures. 6% avoided particular surgical approaches, and many admitted to ordering more tests, making more referrals, or instructing staff to take more frequent observations. And 16% of our respondents were then subjected to some sort of formal investigation at one level or another. Talking about it, 43% of people who responded to our survey spoke to no one at all about the impact that that experience was having upon them. 1.6% accessed any sort of specific local or national support service. And yet talking about an adverse event is extremely helpful. The red arrow there shows the average position of our respondents, and you can see a very strong bias towards people saying that just talking about it was an extremely useful thing to do, and yet almost half of the people who experienced an adverse event spoke to no one. I think there is a difference between errors and complications, and let me illustrate that to you with an extreme example. And I confess that errors and complications are at ends of a continuum. But if you take VTE prophylaxis as an example, then clearly it is an error if someone fails to connect and turn on the VTE compression boots or fails to fit the VTE stockings. And clearly it's a complication if every single thromboembolism prophylaxis step has been taken, and yet the patient still gets a DVT. So there are some things which are obviously errors or obviously complications, but I think there are many things which are not obviously one or the other. Take, for example, a small bowel anastomosis leak after an ileal conduit. Is it true that a small bowel leak from the anastomosis is always a technical failure and therefore an error? Or in the very best of hands, is there a recognized leak rate and therefore a complication? And the reason why I think this is important is that those who reported an error were significantly more likely to have sleep problems, to be more anxious, to drink more, and to smoke more. And those who reported an error were significantly more likely to experience PTS symptoms, even when we controlled for the level of severity of the event. And errors were significantly more likely to result in changes in practice. And remember, not all changes in practice are good. It may not be a good thing that a surgeon stops doing particular procedures that they may be extremely good at because they've had a complication when they did it once. So I think it does matter whether a surgeon views an event as an error or complication. And whilst I'm not trying to skew something to being a complication when it was an error, I'm not sure that surgeons are best placed in the aftermath of an adverse event to deduce whether something was all error or all complication. And so putting some thought into what sort of event it was may well be important in determining how deeply a surgeon is affected. So in summary, folks, surgeons in the UK are profoundly and frequently affected by adverse events. There is great depth and breadth to that personal impact across the spectrum of anxiety, anger, sleep, increased alcohol abuse, and aspects of PTS. There is depth and breadth to the professional impact, and we absolutely must talk about this more. We do well to put some thought into thinking about the difference between errors and complications. And obviously, we are clearly extremely ill prepared for the impact that adverse events will have upon us in the surgical life. And that raises an obvious question, which is, could we be better prepared? And the answer is at the moment, we don't really know, but we'll come on to that. What can you do as a senior trainee or junior consultant? Well, firstly, you can recognize that when something goes wrong, it's going to impact upon you, both in terms of your well-being, your health, and your professional practice. You shouldn't be surprised about that. It's absolutely critical that you talk to someone about it. Colleagues, mentors, previous trainers, maybe colleagues in another hospital, depending on what's happened. But please talk to someone. Please also recognize that resilience is itself not resilient. And it's very well accepted that resilience is not a fixed characteristic. It's not a level of hardness or toughness that you're born with and is not going to change. It's not the case that you will always have X level of resilience. How resilient you are at any one moment depends on a whole multitude of things. And in professional life outside of medicine, it's well accepted that resilience is something that can be enhanced. And given the impact that adverse events have on surgeons, clearly it's of great deal of interest to know whether resilience in surgeons could be enhanced before something bad happens. More of that in a moment. Please, before an adverse event happens, make sure you're aware of local support mechanisms. Occupational health often are surprisingly helpful and knowledgeable. And your hospital may have something like a Schwartz round or similar, where people affected by an adverse event, regardless of seniority, are able to talk openly and frankly about how they've been impacted. There are good national support mechanisms. The fact is that surgeons are extremely bad at making use of them, but they are there and they are available. And a look at the BMA website gives a very comprehensive list of support mechanisms for all kinds of events and stressors that may arise in a doctor's life. Specifically to surgeons, the RCS has good information and has a confidential helpline. And many medical defense organizations have great understanding of how adverse events impact upon doctors and have their own support programs. So do make yourself aware of what is available before you really need to know about it. Just a brief word about surgical resilience. We've done some preliminary work comparing the resilience in surgeons to that in the general population. Resilience is something that can be measured, and there are validated measures that enable you to do it. And this is just from a brief pilot study we did where we took a bunch of surgeons, we measured their resilience. You can see that they start lower than the general population, and we gave them some resilience training. We adapted it from an available program, and we did 3 2-hour one-to-one sessions with a resilience trainer, and we repeated the measures of resilience training to see whether the resilience can be enhanced. And this is not a randomized or controlled study, but we were really encouraged to see that there is evidence that measurable resilience in surgeons is something that can be improved by training. And based on this preliminary study, we have now just completed a much larger randomized controlled study of resilience training in surgical trainees, just over 80 participants randomized to receive resilience training or not. And although I can't tell you the results of that, I'm really excited to know whether or not resilience training is something that can make us better able to deal with the impact of adverse events when they come our way. Moving on from that resilience side, the fact is that you are an ordinary person doing an extraordinary job. You're not tougher or more resilient than anyone else. Complications will come your way, and because you're ordinary, I'm afraid, you're going to be affected by them, perhaps more frequently and to a greater extent than you had previously realized. Please find out about local and national support. Please do talk about how you feel when something goes wrong. And please, in the future, if we really think this works, then consider taking some formal resilience training. After all, you train for just about everything else that's an inevitable aspect of consultant life. Why not train for this? So thank you very much for listening. Do have a look at our surgeonwellbeing.co.uk website if you're interested in the work that we're doing, or drop me an email. I would be really delighted to hear from you. Thank you very much indeed.
Thank you, Professor Turner, for such a thought-provoking talk. I especially probably should have considered the difference between an error and complication before now, but I've certainly taken that away from today. We've had a few questions submitted in advance, so in no particular order. Do you have any useful steps or tips in improving coping when we have made a mistake or there has been a complication?
I mean, thank you, Neil. Great question. I mean, I think the starting point here, of course, is to recognize the inevitability and not to be surprised that it has an impact upon you, to allow yourself some time to process that and to talk to others, as I've said. One of the things I'm really interested in is whether we can actually come up with some sort of first aid response. I didn't talk about it today, but we've been working with a number of stakeholders who have something to say in this space. So examples would be the MDU, BMA, RCS England, and we've taken advice from psychologists and experienced medical directors to see if we can come up with some sort of first aid package, a sort of list of do's and don'ts. And we hope to cover some of the things like, should you have the following day off? Should you have the week off? Should you stop operating? When should you come back? Should you be mentored? And of course, you know, it's hard to be prescriptive about that when there's going to be such a range of errors and complications and impact. But I hope we'll be able to say something valuable in that space, and something that a clinical director or medical director could reach for to make sure that they've covered all bases. But at this stage, I think it's pretty simple, really. Recognize it's going to happen. Recognize you're going to be affected. Don't be surprised by it, and talk to someone about it.
Thank you. I actually have also had a very related question submitted, which is, and you sort of alluded to this with what we currently do, and urologists are generally nice people, but how do we support our colleagues and peers when they have a complication?
Yeah, again, thank you. I mean, I think it is to encourage them to do some of the things we were just talking about, in terms of recognizing it, not being surprised by it, and talking about it. One of the things I'd really like to see is that this would become something that's automatic. And it wasn't me that came up with this illustration, but I think it's a really helpful one, which is the head injury protocol in rugby. You know, when someone has a head injury, it is a given that they are taken off the pitch and go through some sort of assessment, regardless of the apparent severity of that injury. And it's not possible for someone to shake it off and say, no, I'm fine, or to say, check me out later, because the protocol is that you're checked out there and then. And I would like to see it as automatic when something goes wrong, an error or complication, that there is a process where the involved surgeon is taken to one side and words along the lines of, this has happened, you are of course going to be affected by it. Can we just explore a bit how you're feeling? And can we just make sure that some of the important things have been done, like, if necessary, have you contacted your medical defence organisation? Has the trust duty of candour been fulfilled? And if it hasn't, are you the right person to do it, or do we need to get someone else to do that for you? Those kinds of things. And that relates to what I was saying about a first aid pack. But I think we absolutely have to take the responsibility away from the involved surgeon to stick up their hand and say, hey guys, can you help me because I'm suffering here? That presents too much of a barrier. And the evidence shows that surgeons are rubbish at asking for help. Claire Garada, former president of the Royal College of General Practitioners, now runs Practitioner Health Programme, a service exclusively to support the mental health of doctors, has described surgeons as a minority within a minority. In other words, doctors are rubbish at asking for help and surgeons are doubly rubbish. And we have to take the responsibility away from the affected individual and make this a process.
Thank you. Do you have any insight into why there seems to be some people who shrug off having a complication and those that really seem to be hit as hard as some of the worst hit in your study?
Yeah, great question. I mean, obviously we are all different, although I made the point, and I really believe this, that resilience is not a fixed characteristic, and for us all, our resilience can go up and down according to circumstance. There are, of course, different levels of starting resilience because we have different personalities, and therefore there are individuals. And if you take resilience as in simplest term as ability to bounce back, then there are some individuals who will bounce back more easily than others. And just as we are comfortable in recognizing in our surgical colleagues that some people are better educators, some people are better researchers, some people acquire the technical skills of surgery more quickly, so we must recognize that there will be variation between us in terms of how impacted we are and how much support we might need. But I think also implicit in your question is something to do with the sort of what I've called the sort of multi-hit hypothesis of complications. Is it the case that we can only take so many bullets before we start to go down? Or is it the case that the more complications we experience, the better we are able to process them because we've bounced back before and we know we can bounce back again? I don't know the answer to that, although we've got the data to answer that question. We haven't actually analysed it yet, but I have a sneaking suspicion that it is a myth that senior surgeons are better able to bounce back. And I actually think it might be the complete reverse of that, that the longer you're in this game and the more adverse events you experience, coupled with the higher expectations of senior surgeons, this shouldn't happen to me, I'm the one people look to for help, not the one who has complications. I think we might find that it's senior surgeons who are more profoundly affected, but that's just a hunch at the moment.
Thank you. I think it'd be really interesting also to see if it's the rate of complications that we have in over a period of time and whether or not actually returning to baseline means that we're better able to deal with them in the future.
Yeah, sure.
Did you see in relation specifically to your talk a higher rate of change in practice in the 16% of people that were formally investigated? And that is a response to the formal investigation?
Yeah, great question. The only honest answer I can give is I don't know. We obviously have the data on all the individuals, and that's something that we could look at, but I simply don't know the answer to that, I'm afraid. But yeah, it would be very interesting to explore that further.
And lastly, you mentioned that surgeons appear to have a lower baseline resilience compared to the general population.
Yeah.
Do you think that that's the population specifically that you studied in that pilot, or do you think that actually across the board surgeons have a lower baseline resistance, and why?
Yeah, it's a great question, and you're right, that's what the slide showed. Again, I don't know, and if I was to take you back to that slide, you'd see that actually the axis doesn't start at 0. So although it looked like a big gap, it wasn't all that big, and the pilot was based on 10 people. I don't know, and of course, you know, in all studies of this nature, you have to ask, well, what's the general population? Was it other similarly aged professional people, or was it truly a cross-section of society? What I do know is in the psychology literature world, it is acceptable to use measures of general population resistance as a denominator to which to compare your experimental population. I think what I am confident in saying on the data that we've generated so far is that surgeons are not more resilient. And if the profession just grasped that, I think that would be a step forward. We're simply not tougher. We're simply not able to bounce back better. And we will be impacted in the same way that anyone else would be, as I said in my slide, because we are ordinary people doing, at times, an extraordinarily taxing job. And even if that slide is a myth, and we start at the same level of resilience as the general population, surely there's value in seeing whether we could become more resilient because of the things that are going to be thrown our way.
Thank you. One last question, sorry, that I've had. Do you feel, or do you have any information on whether or not forcing someone to talk about it does more harm or good when they have a complication?
Yeah, I don't know. And, you know, we're never going to force, no one, even if we wanted to, and we wouldn't, we would never be able to force someone to talk about it. And I guess we're not talking about placing someone in the psychiatrist's chair and looking them in the eye and saying, tell me how you feel. But at its most basic level, I think this first aid response, for want of a better phrase, at least gives that person an opportunity to run through if nothing else, to run through a checklist. Yes, I've dealt with the duty of candor. Yes, I've dealt with my medical defense organization. And those couple of quotes I put in from urologists simply show that process just doesn't exist, even at a mechanistic level. Let's forget the emotional and caring level, simply at a mechanistic level in a trust. In the vast majority of trusts, there is not a process that knows how to handle the surgeon. Yes, they know how to handle doctors where there are issues of behavior or competence. There are processes for that, but there's no process to help a surgeon who has not misbehaved and is not considered to be incompetent, but to whom something bad has happened. And yet that surgeon needs some sort of mechanism from the trust, and that mechanism doesn't exist. So even if we can't, we're not talking about making people navel gaze, but we are talking about putting a supportive structure in place which has anticipated the things that the surgeon will either need to know or need to do.
Great, thank you. Thank you for answering all the questions as well. So that rounds out this session, and I'd like to thank all of our speakers for their fantastic contributions, and I'm sure we can all take away more than a few points, both finishing up before CCT and then in our first year or two of practice, as well as complications, and we look forward to seeing the first aid package that's going to come and support us throughout all of our careers.